adolescent care gap, putting adolescent sexual and reproductive health QI strategies into practice. Our session today is titled Youth-Friendly Strategies for STI Prevention and Treatment at Community Health Centers. Just as a quick disclaimer, this meeting will be recorded by the host. Individual participants are welcome to record this meeting on their personal devices. And by staying in this meeting, you automatically consent to be recorded. Please just note here, the audio connections, you can either phone in if you need to, or you can use your computer audio. Here you can see the unmute or the unmute and start video features. We're going to leave folks unmuted, muted and with videos off for this event. You can ask questions or make a comment using the Q&A box and just click send. And we're very excited to hear your questions throughout today's presentation. And then just as a quick note, today we are offering continuing education credits. So they are available through the CDC train system, and this is a separate system from your registration. And instructions for completing the evaluation and obtaining CE will be emailed to attendees after today's webinar. The deadline for obtaining the continuing education credits is June 8th. And then just to quickly note, we do have one disclosure today for our guest speaker. So please note that here. And so again, just friendly reminders that the meeting will be recorded. All attendee video and audio functions will be disabled by the host. We encourage you to submit your questions in the Q&A box. And then we will just have a quick survey after the event has been completed. And we ask that you fill that out if you can. So thank you again for joining today's session. As I said, today's the first of 3 sessions where we'll be doing a deep dive into the brand new launch of the Quality for Teens Quality Improvement Package to improve adolescent sexual and reproductive health. In each session, we will dive into a key topic and goal area that is included in the Q4T or Quality for Teens package. So today we're focusing on those youth-friendly strategies for STI prevention and treatment at community health centers. So I know that we have a lot of different folks in the room today. We have clinicians, we have nurses, behavioral health staff, quality improvement leads, and health center management. And I just want to emphasize that there are elements of the Q4T package that are useful for all types of health center staff. And so we are just really excited to have you all here with us today. So to start, my name is Mikayla Bobrow. I am the project lead on the Quality for Teens project from the CAI side, and I've had the pleasure of working with NACHC and CDC on this initiative over the last 3 years. I am joined today by Dr. Natalie Neu, who is the medical director for the New York City STD Prevention Training Center and a professor of pediatrics at Columbia University Medical Center. Dr. Neu is trained in pediatric infectious diseases and has specialized in adolescent HIV and STI care for the past 25 years. Dr. Neu participated in the writing of the 2021 CDC STI treatment guidelines as a work group member. And Dr. Neu treats children of all ages from infancy to young adulthood with a specific area of interest in sexual health concerns, such as sexually transmitted diseases, vaccines, and HIV. So we are thrilled to have her here with us today, and we are excited to have you all hear from her in a few minutes. So I want to quickly share our agenda for our hour together. I'll start by just sharing with you all a bit about the Quality for Teens or the Q4T package, what it is, how you can access it, and then we will spend the majority of our time hearing from Dr. Neu about youth-friendly strategies for STI prevention and treatment at community health centers. And then lastly, we will leave a little bit of time for you all to ask any questions before we close out. Before we jump into all of that, I would love to do a quick poll question to learn about the STI screening and follow-up policies, practices, and services at the health center or health clinics where you work. Liz, are you able to launch that poll? And I am not able. Okay, perfect, great. So the statement here is all sexually active cisgender women less than 25 years of age, transgender men, and gender diverse people with a cervix less than 25 years of age are screened for chlamydia and gonorrhea annually at my health center or clinic. So if you can just write in if this describes your health center well, almost there, just getting started, or doesn't describe us. And I'll give folks maybe 10 more seconds or so to answer the poll question. All right. It looks like we're getting a good number of responses. I'm going to go ahead and close out the poll. So as you can see, there's really responses across the board. 36% say describes us well, 29% almost there, 17% just getting started, 18% doesn't describe us. And so I really just want to emphasize that there are goals and strategies and tools and resources for folks in the QI package that I'll provide a lot more detail on in just a moment, that can help in any of these different stages that your health center may be in. So I'll go to our next poll question. The next statement that I'll have you respond to is sexually active male adolescent patients who have sex with males are screened for chlamydia and gonorrhea annually at my health center or health clinic. So again, please share if this describes your health center well, if you're almost there, just getting started, or doesn't describe us. And again, I'll give about 10 more seconds or so for you all to answer this question. All right, we can go ahead and close that out. So it looks like 46% about said describes us well. So it looks like there's more folks that are doing this on a more regular basis, but still absolutely some folks saying almost there, just getting started, or doesn't describe us. So again, just no matter where you are in your quality improvement journey, there are improvement areas for you in this package. So now that we have a little bit of a better understanding of where your health center is at, specifically regarding STI screening and follow-up services, I would like to introduce you to Q4T. So Q4T is a quality improvement package containing a collection of strategies, tips, tools, and informational materials to promote optimal adolescent sexual and reproductive health care, or ASRH for short. So it's a ready-to-use resource for health centers. There is a digital version that's available online, as well as a more detailed PDF version that anyone can download. And the purpose of Q4T is to facilitate the scale up of quality improvement of ASRH services in community health centers, with the primary focus being on federally qualified health centers, also known as FQHCs. FQHCs are trusted safety net providers that serve almost 10% of US adolescents in communities across the country, or approximately 2.3 million teens every year. Q4T is organized in two main sections. We have ASRH clinical services and youth-friendly practices, and within those sections, there are 8 improvement goals, which you can see listed on the slide. So these improvement goals were selected based on lessons learned from previous ASRH initiatives, as well as current guidelines and recommendations, published evidence, and stated importance by adolescents in published literature. This slide here shows the homepage of the Q4T website. You can see right in the middle of the page that there's a short video you can watch that will tell you about what Q4T is and how the strategies can help your health center improve ASRH services. Right above the video, you can see that there's a drop-down bar that says ASRH improvement goals, strategies, and tips for health centers, which will drop down and show you those 8 improvement goals that I just showed on the previous slide. And then on the top bar, you can see that there's an organizational readiness section, a needs assessment section, an improvement goal section, and a section for supplemental tools and resources. And I'll just quickly show you what those pages look like now. So the organizational readiness section can help health centers better understand both how to use Q4T and understand if they're ready to use it. And this includes information on securing leadership support, identifying a clinical champion, identifying an improvement team, selecting a QI framework and techniques, identifying performance measures to track progress, and planning for aligning new workflows with the EHR. The needs assessment section was created and tailored for Q4T and can help health centers identify which goal or goals their improvement team would like to focus on. There's also a link in this section to an interactive action planning tool, which provides space to track progress towards selected improvement goals. This slide here just shows 2 screenshots from the chlamydia and gonorrhea screening and follow-up improvement goal. So in the first image on the left, you can see at the top that we're looking at the chlamydia and gonorrhea screening and follow-up improvement goal. And then below that, you can see written in purple, it says strategies. And below that, you'll see the 5 change strategies that are included in the package that can help your health center achieve that goal. So the color of the change strategies indicates the focus area. So that first change strategy it says key foundations and is in dark blue. And that means that it's this change strategy is related to assessment, policy, and environment. And on the left-hand side, you can see that there's a key for the different focus areas that provides a description for each focus area. In the second image on the right-hand side, you can see the details for the second change strategy. And so that change strategy is train the care team on recommended chlamydia and gonorrhea screening for sexually active adolescents and tracking, following up, and treating those who have positive screens. So below the change strategy, you can see implementation tips in blue. And these are ideas for health centers on how best to implement that selected strategy. And then below that, you can see that there are tools and resources that correspond with each change strategy. And then lastly, as part of the supplemental tools and resources section, Q4T also provides example performance measures related to the 8 different improvement goals. These are not an exhaustive list by any means, but are intended to help improvement teams consider what performance measures could be used to monitor progress toward and in success in achieving the selected improvement goal. So I know that that was a lot of information, but we just wanted to quickly share with you how the QI package is laid out. And definitely we encourage you all to take a look at it in more detail after today's talk. But now I am very excited to pass it over to Dr. Natalie Neu, who will now share with you about youth-friendly strategies for STI prevention and treatment. Natalie, I think you're muted.
Thank you. Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. And thank you to the organizers for allowing us to present today. Next slide. I'd like to acknowledge our team who's helped with this with these slides and the data that's in them. Next slide. And the objectives of today are really to give you the basics around STI testing in youth. We want you to be able to recognize the importance of screening, to review the treatment and management of common STIs, to review the landscape of STI prevention options, and also to be able to discuss strategies to engage challenging populations. Next slide. So I know that I'm speaking to the choir here a little bit since you're all in healthcare and most of you read the newspaper and you know that STIs is a worsening epidemic in the United States. In the US, the CDC presents data and we know that there are over 1.6 million cases of chlamydia. Although this is down, this still is a ginormous number. For the other STIs, we see that exponentially increase over time. So 11% for gonorrhea, and congenital syphilis has just ballooned over the last several years, over 150% increase since 2018. So this is a problem. It's also very expensive. We know that 1 in 5 folks in the United States are getting STIs, and it's going to cost us more than $16 billion to treat them. Next slide. And we know that STIs are not benign. So if we don't test, next slide, we know that we're going to have problems with pelvic pain, inflammatory, chronic inflammatory disease, infertility, even such things as urethral strictures. And we know for congenital or for syphilis, if it's not diagnosed, it can lead to permanent vision or hearing loss. Next slide. So why is it important that we're talking to you about STIs and youth? Well, we know on the figure on the left shows that by age 18, 65% of the population has had sex. On the figure on the right, we see the burden of STIs in this population, the 15 to 24-year-olds. They represent 50%, not in every single disease, but across the board, 50% of the new STIs diagnosed. So this is why it's really important for us to talk about youth and STIs now at this time point. Next slide. So are we missing opportunities to diagnose STIs? Well, we are. In a study in pediatrics in 2021 that surveyed parents and adolescents, they reported that parents and adolescents said that it's important to talk about sex. But in this study, they showed that less than a third of the adolescents actually reported that the providers did talk to them about sex. And in addition, almost 50% of those, especially in the older age group, reported that providers did not discuss confidentiality. And we all know that confidentiality in the area of reproductive sex is very, very important to discuss with these clients. Next slide. So how can we improve our sexual health assessment for our patients in the clinical setting? Well, we need to know how to do a needs assessment. The beginning of doing a needs assessment is setting up a welcoming environment. It has to be confidential. It has to be friendly. It has to be a place where you have clear communication, and it has to be accessible for the patients. And oftentimes youth need different hours than what we're really used to. It's not to say that parents are excluded, but we need to provide it in a setting where it's focused on youth, which protects them in this area. And we also can bring parents in, but we need to protect them to allow them to have their sexual and reproductive health addressed. Next slide. So STI care is critical, and it can be provided in health centers and community health centers specifically because you serve a medically underrepresented and underserved populations. You provide primary and secondary prevention all the time. So you're used to doing all the things that happen in STI care. Just to remind everyone what we're talking about, primary prevention is where you prevent the infection from happening. So you talk about condom use, vaccination, medication prophylaxis. Secondary prevention includes early detection by screening, treatment of STIs and syndromic treatment, and prevention services such as expedited partner therapy, pre-exposure prophylaxis, post-exposure prophylaxis, and doxy-PEP. We know now from multiple studies that comprehensive sex education is not happening in schools, or it's being limited in the client that we're facing now. It's definitely important for healthcare centers to take a lead in this area of sexual health and STI care. Next slide. So just to review a couple of more terms here, what does screening and diagnostic testing mean? How are they different? Screening tests are when you're doing a test on a person who has no symptoms. A diagnostic test is when you're testing somebody for a disease and they have symptoms. Next slide. Why is this important? Well, how symptomatic are STIs? As you can see from this figure, the bulk of this, it's supposed to be an iceberg, falls below the line. Most STIs are asymptomatic, and those are in women. Some STIs are symptomatic, and they're in men. You can see above the line there. So this is why it is so important to screen for STIs, because the majority of sexually transmitted infections are asymptomatic. Next slide. So why are we, again, talking about adolescents and young adults? Well, we're talking about them because they have particular risk factors for sexual infections. So they have behavioral and biologic things happening that predispose them to STIs. Things like multiple partners, or practices such as substance use, use of social media, barriers to access care that might predispose them or put them in a situation where they might acquire an STI. Youth right now also have unique issues where they can consent to STI testing and diagnosis and treatment, but emotionally they might not be ready to do that, or cognitively they might be immature, so they can't totally understand the landscape of what they're entering into, and they might have fears around doing this. This is why it's so important for us to set up a positive environment to talk about sex and to be able to uh, handle STIs and diagnose them in your setting. Next slide. So what does that mean? That means presenting sexual health to youth as a normal part of life and health. So normalizing the sexual discussion, enveloping it in a discussion about psychological, psychosocial, and clinical issues, addressing their concerns about starting sex or sexual dysfunction, and talking to them about comfort and pleasure. How does this then help us, take action? Well, understanding this information that your clients are giving you allows you to then institute early detection and with screening, identify sexual health problems, um, put in preventive measures to help with unintended pregnancies, and then ultimately to reduce transmission of STIs. Next slide. So the CDC has some great tools on them. So you're going to hear a lot about tools that are available to you, but they have this taking a sexual history tool that talks about the 5 Ps. So it gives us a framework for how to talk about sex. And I was just at a conference yesterday where an adult infectious disease fellow told me she really didn't have practice or felt comfortable in having a sexual health discussion, which made me cry. So I was like, it's the 5 Ps: partners, practices, protection, past history, and pregnancy intention. Next slide. So in our clinic, what we have done, and in some settings, people have expanded the Ps, especially when you're talking about youth, to include: what pronoun do you like to be addressed by? Are you having some psychosocial issues right now? Are you concerned about performance? Do you watch pornography? Is that driving your sexual behavior? And what kinds of prevention, so prevention from HIV specifically, are you interested in? So this is the expanded P framework. If you have these 5 things plus 5 in your mind as you're approaching your teens in your discussion, it'll make things so much smoother, and you'll be able to access the information that you need to help them with their sexual health. Next slide. So when we talk about the 5 Ps, how did the CDC change this framework in 2021? Because they did. They changed it in that they made it more gender neutral. They also encourage providers to really talk about body parts involved with sex. And they also encourage everyone to talk about STI prevention. So these are key points that they added to the 5 Ps that are very important for you to use, and language to use, in terms of talking with clients about sexual history. Next slide. So in taking the sexual history, it's not just a checklist. It's not just let me go through the 5 Ps. It's not totally about what do I ask, but how do I ask it, especially with youth. Next slide. We feel that it's so important to have a sex positive approach to taking a sexual history. So you're celebrating that sex is part of life. Everyone has it. So let's figure out how to make it a positive experience for you so that you don't have any fears going into this, and you have a positive outlook about sexual relations. Next slide. So the sexual health assessment and clinic workflow can be incorporated into your general health assessment. And that's what we're looking for. They don't have to come in just asking for STI testing. You can do this assessment at any point that anyone enters your program. So you are going to, you want to assess their knowledge, their attitudes, their skills, and the behaviors that they're encountering. Part of the way to do it with youth are, you can, instead of asking them, sometimes using a tablet or using a text where they're they're recording the information, they don't have to directly say it to you, can be very useful. You want to make sure that you're doing this in a confidential setting and that there's privacy around it and that they understand that this is confidential and private. Next slide. So when taking a sexual history, you want to talk about behaviors, sexual health, and the benefits. You want to try to eliminate that word of risk from your vocabulary, which is so hard. I catch myself all the time where it slips out. But you don't want to talk about risk behavior or risk assessment, right? We want to talk about sexual, pleasure, and also preventing negative outcomes or preventing complications later on. Next slide. So what kinds of questions could you ask? You can ask, do you have any new partners? Do you use condoms with sex, or do you prefer unprotected sex? Have you ever had a sexually transmitted disease or know about your partners? Have you ever taken medication for an STI? You want to understand what kind of substances they use because you want to know how it's changing their behavior and how it changes their sexual behavior. Next slide. You want to be mindful about your verbal words that you're using, but also your face and your facial expressions. Next slide. You got to have a poker face, right? The mask sometimes helps, but everyone knows that they can definitely read our eyes when they say, oh yeah, I've had a lot of partners. So try to be mindful of that as well. Don't judge, don't lecture, and don't preach, and don't leave the conversation or start the conversation with a blaming sort of verbiage. Next slide. So a word is not just a word. Next slide. People have, if you say, are you sexually active? Next slide. Some people might interpret that as, no, I just lie there. Next slide. Or no, I just have sex every once in a while. Next slide. No, I only have sex with one person. Next slide. No, really, I just have oral sex. So there are many ways to interpret, are you sexually active? Likewise, people, when you say how many partners do you have, people think partners means a steady person. So they might not respond to that. So how many persons have you had sex with might be a better word to use. Next slide. A really nice way to sort of implement the sexual history is provided by the New York State, and they have this goals framework the Department of Health had. It's a sex positive approach. Next slide. They talk about universal screening, the benefits rather than the risks, positive interactions, promoting engagement, and having your patients want to talk to you about their sexual health. Next slide. To do this, you really have to sort of set yourself, give a preamble. You have to have opt-out HIV and STI testing. So, hey, everyone has this in my clinic. You're good with that? Open-ended questions, So, how is your sex life? Do you meet a lot of people? Just leave it open. They're more likely to give you an answer. And then listen to what they're telling you. If you're not getting the answers, you might have to dive deeper. If somebody says, yeah, I'm sexually active, well, where are you sexually active? Are you having oral sex, vaginal sex, anal sex? And those words have to come out because you need to know in order to decide where to test and then how to treat. Next slide. After you do an appropriate sexual history, this is the S part of it. These are the action steps. All these things can happen after you get your information. HIV screening, 3-site extragenital testing, hepatitis C, vaccinations, PrEP, behavioral counseling. It's all part of your sexual health screening. Next slide. The CDC has, the standard talk, test, and treat, and this is what we want everyone to do, and we want it to be part of every health screening visit. Next slide. So let's talk about a couple of cases to dive a little bit deeper into some of the specific STIs that we need to talk about today, that we need to know that you know how to test and treat. Next slide. So this is Jack. He's a 16-year-old. He comes to your clinic as a walk-in. He says, oh, I just want to get, I want to get some STI testing. I don't have any complaints. Next slide. When you dive deeper and you're going to do the 5 Ps, you find out that he's had 6 male partners in the past 2 months. He meets partners with an app. He has 1 regular female partner. He practices oral, giving and receiving, vaginal and anal intercourse, both insertive and receptive. He uses condoms sometimes, but he doesn't like how they feel. He had chlamydia in the past, and he doesn't really want kids. Next slide. So you got a lot of information there just by sticking to the 5 Ps. You do your workup that you do, HIV test, Hep C, 3-site screening, right? Because he's identifying as an MSM, a man who has sex with men, and a man who has sex with women. And he doesn't have any symptoms, so you won't do a gram stain in this case. Do syphilis testing, and you could offer him PrEP. Next slide. So the CDC has some very specific recommendations around gonorrhea and chlamydia screening. So for men who have sex with men, they say at least annually at each site of exposure. So you are having penile sex, rectal sex, anal sex, you have to test there, and oral sex. In most situations, however, they have expanded the screening to every 3 to 6 months because someone who has the sexual history that you just got is probably at increased risk. So you could screen somebody at least every 3 to 6 months. That's the same recommendation that is given for those who are taking pre-exposure prophylaxis to prevent HIV. Very similar to what we're also offering for those with HIV. For pregnant women or non-pregnant women, at least annual to those under 25 who are sexually active. But they also state, and I'll reiterate this later, that rectal testing in women can be done based on sexual behaviors and exposures in a shared clinical decision-making. For men who have sex with women, they say consider in high-risk settings. So if you are in an adolescent clinic or you're in an STI clinic, you're in a high-risk setting. So pretty much test everybody every 3 to 6 months is the goal that I think everyone should have, and it just keeps it simple. Next slide. So in our clinic, how do we get our space ready for testing? We make these kits in advance. We have them all set up. It has 3 different testing tubes. So 1 for oral, 1 for anal, and 1 for the urine. Have it available in every room. Next slide. If you have, you allow your patients to do self-screening, which is a game changer in terms of getting more sites tested, and patients actually prefer this. Pick a site in your bathroom where you can put some information, a guidance about how to do it, and also have your test kits available or give it to them so they could take it in with them, labeled, ready to go to do the 3-site testing. Next slide. There are a lot of online guidances available for you that you can post everywhere in your clinic, normalizing this is what everyone does. Self-collection is easy. You open the kit, you twirl it around in the anal region, you put it back in, break it off, put it in your bag, and give it back to me. My clients love doing the testing themselves. I often do the oral, but they love doing the anal testing themselves, and it definitely has improved our uptick of the 3-site testing. Next slide. So why are we doing 3-site testing? Next slide. This is another change that happened in the guidance. So in the guidance, they said extragenital testing can be offered to men who have sex with men who do not report exposure at sites after detailed explanation due to underreporting of risk factors. For women, they said, consider rectal testing for females through shared decision based on sexual history. Next slide. This is a huge increase or change in the guidance. So why did they do this? So they did this because of several papers that were in the literature that supported this new change in testing protocol. This study was one that was done in Kansas City, about 10,000 encounters, and they were identified that there were multiple misdiagnoses, and that if you did three-site testing, that it would change your management. Next slide. So in this study, most of the gonorrhea and chlamydia that were in men who have sex with men would have been missed if extragenital testing had not been performed. In addition, a third of the extragenital gonorrhea and chlamydia in men who have sex with women and women who had sex with men would have been missed had only urine testing been done. That is shocking, right? Next slide. So this figure, next slide, shows you on the left-hand side is gonorrhea, and on the right-hand slide is chlamydia. On the top part of the graph is pharyngeal testing, and the bottom is rectal testing. The dark bars are the things I want you to focus on. Those are indicate tests that are positive who only had extragenital testing. So you can see here that the dark bars sometimes represent 90% or more, especially on the bottom on the bottom figure. Next slide. And this is for men who have sex with men. So you see here, men who have sex with men, rectal gonorrhea would have been missed. The big dark bar. You would have not detected that had you only done the top, the urine. It's shocking, right? Chlamydia on the right for men who have sex with men. You would have missed that had you only done urine. Next slide. When we're talking about women, we would have also missed the cases of women who had gonorrhea and chlamydia. It's a smaller proportion of the total positive, but we're still missing a significant portion, which can lead to reinfection. Next slide. And not to say, it changes your management. So let's go back to our case for a second. He comes back and he says, well, I have to be honest, I'm a little embarrassed, but it hurts when I pee. And this sometimes happens as they're like walking out the door and you're like, what? Why did you tell me before? Next slide. So in this case, you would do a gram stain and you might see intracellular gram-negative diplococci. What is it? Drum roll. Next slide. This is gonorrhea. Next slide. So as you can see from this figure, this age population, youth 15 to 30, make up the majority of the cases of gonorrhea in the United States. You can see within the red box. Men more than women. Next slide. So what changed in the guidelines in 2021? Well, the treatment for gonorrhea changed. The dose increased to 500 milligrams IM, and it's a weight-based dose. So if you have folks coming in who are above 150 kilos, it's 1 gram IM. Next slide. If he were to come in and you couldn't do a gram stain and you weren't sure that it was gonorrhea, you would have to treat empirically for both gonorrhea and chlamydia. And the guidelines changed in that as well for what's the first drug recommended, and now it's doxycycline. 100 milligrams twice a day for 7 days. The other thing that changed, or that's now in the guidelines, is the alternatives. So gentamicin, 240 milligrams IM, and azithromycin 2 grams once is recommended as an alternative. There are oral regimens, but the dose is higher. It's up to 800 milligrams. So you have to be very careful if you're giving, for example, expedited partner therapy. If somebody can't come in for the injection and they don't have pharyngeal disease, then you can give them cefixime. There are no reliable alternatives to IM ceftriaxone for gonorrhea. Next slide. So why did these changes occur? They occurred because of changes, or what we know now about in antimicrobial stewardship. We know that Neisseria gonorrhea, the resistance rates are increasing significantly. So in some places it's 20 to 30%, our fluoroquinolone resistance, azithromycin resistance is increasing. And also the amount that you need to achieve a level to kill the pathogen has changed. And so that's why the dose increased. Likewise, we know from pharmacokinetics that you need a higher dose to achieve a level. So a higher, if you have a higher minimum inhibitory concentration, you need a higher dose of the drug to kill that bacteria and especially to kill it in the throat. So this is why it changed. Next slide. So when we reviewed Jack's tests, we sort of knew his urine test was positive for gonorrhea, but he also had rectal gonorrhea. So you're going to treat him, as you did, with the IM ceftriaxone at the higher dose, 500 milligrams. Next slide. But what are you going to do for follow-up? So you heard about the 5 Ps, you know what you're doing for testing. The next step that you have to know what to do and you need to have it down is how to do the follow-up. You need to tell them, abstain from sex for 7 days. If you still have symptoms, please come back in because we need to know if you have a resistant infection. If you have disease in your throat, you need to come back in within 7 to 14 days so we can retest you. If you're pregnant, you have to come back in within 4 weeks. If you are everybody else, I want to see you back in 3 months because the incidence of reinfection is so high. I really want to retest you to make sure you didn't get gonorrhea again. So you need to know all these talking points and have it in your note so that they come back and get checked up again. Next slide. Why do we say 14 days for coming back for pharyngeal infection? Well, the problem is with gonorrhea is that our tests are too sensitive. We know that in PCR testing or NAT testing, nucleic acid amplified testing, we know that you can have non-viable organisms. So if you see in this table here, you have 8.7% of organisms might persist within the first week. The last line in this table in the middle, you're at 15 to 28 days, you're down to 1%. So it's unlikely you're going to have a false positive test if you retest them after 15 days. This is why we recommend them coming back in that time frame. Next slide. Let's move on to case number 2. So Jill is a 14-year-old. She's sexually active with several male partners. One of them recently got diagnosed with chlamydia. Next slide. Again, we have it down. We're going to ask the 5 Ps. Partners, practices, protection. So she has 2 partners in the last 6 months. Those were males. She also has a female partner. She practices oral sex, giving and receiving vaginal and anal sex a couple of times. She uses condoms about 50% of the time, but never for oral sex. Ew, why would I do that? A room for education there. She's had chlamydia in the past, and she doesn't want kids right now. Next slide. You're going to do your workup, includes all these tests and 3-site testing because she has sex with men, sex with women, and sex at every site. And because you're such a great provider, you asked all those pertinent questions and found out where she was having sex, at what regions in her body she was exposed. Next slide. So this brings up, what could she have? She already reported she had chlamydia. She could have gonorrhea. She's not reporting any symptoms. We know women are mostly asymptomatic. But chlamydia is one of the more prevalent organisms, and we see that here, 15 to 14% in the causing non-gonococcal urethritis. There are other diseases that we're not going to talk about today that you need to know as well. Mycoplasma genitalium, because it's going to come up on some of your, like if you use one of those big screener tests, it often comes up. Trichomonas, herpes, and other bacterial organisms can also cause urethritis. Next slide. Chlamydia, in terms of the epidemiology for chlamydia, here you really see how chlamydia is more prevalent in women, and especially in this age range, 15 to 30. This is why we want you to do your sexual history taking and find out what organs are exposed to sex and do your testing. Next slide. So the treatment guidelines again in 2021 changed for chlamydia. It's doxycycline twice a day is the preferred regimen with azithromycin as the alternative. Next slide. It changed as well because of microbiologic failures, and especially in men and men with rectal disease. Next slide. What are some of the studies that showed this? So in this study, they showed that azithromycin had a great efficacy, 97%, but doxycycline was actually 100%. Although it established non-inferiority to azithromycin, doxy still was a bit better. Next slide. Another study that was done looking at 7 days of doxycycline for men who had sex with men in rectal chlamydia showed that doxycycline was superior by 20 to 26%. Next slide. And this study, women in studies that looked at anal rectal chlamydia disease in women who had concurrent vaginal infection, they showed that women had disease. So rectal infection was not uncommon among women, and it represented 33 to 83%. So we know women have anal chlamydia, and therefore doxycycline should be the drug for both men and women. Next slide. So how do you pick? So you have to weigh, different factors. Access, adherence, confidentiality, for example. We know in adolescents, sometimes there's a study that was done in ED where the adolescent was prescribed medication and only 60% of them went to get it. So that is not that helpful. Adherence, though, studies show that youth can take doxycycline, 60 to 90% of them can. So it's ease versus efficacy. You have to weigh the options. Next slide. In certain populations, like pregnant women, those who have allergies, azithromycin is the drug of choice. Next slide. In our clinic, we do shared decision making. So if somebody has rectal chlamydia, we say take doxycycline twice a day, 7 days. If somebody's possibly pregnant, it's azithro. But in all other cases, it's shared decision making with an emphasis towards doxycycline because we know the efficacy is better. Next slide. So again, the same follow-up is really important for you to have. No sex for 7 days, repeat testing in 4 weeks for pregnant folks, repeat in 4 weeks if you're using azithromycin for rectal chlamydia because it's not recommended, and then 3 months for everybody to test for reinfection. Next slide. You gave her doxy, you did all your testing, and hopefully she'll follow up. Next slide. So the other thing you can do in your setting is prevention. So prevention is giving partner therapy as well. So expedited partner therapy. It is allowable and permissible in most states in the United States. Next slide. Expedited partner therapy, the CDC also has guidance about what to give. And basically you're giving whatever you gave the patient. So chlamydia, doxy, or gonorrhea, cefixime, if you have to give pills, trichomonas, it's metronidazole. So it's easy. If you remember what you did for the partner, do this for the patient, do the same for the partner. And this is allowable. The difficulty comes in how do you work it out in your electronic medical record? And those are systems that I really advise you to work out in advance. Or for sure, tell the patient, bring your partner in. And otherwise, you might get reinfected. Next slide. So in general, for a summary for the guidelines, what we want you to know is that when you see somebody in clinic, either for sexual health or for other things, take a sexual history. Offer universal STI testing and HIV testing. Educate all your patients about prevention and prevention options. Test extragenitally. I hope I've proved to you that women have anal STIs and so do men. So please test because otherwise you'll miss those infections. Treatment regimens for gonorrhea have changed. the dose has increased and it's weight-based dosing. For chlamydia, likewise, it's now doxycycline as the preferred regimen. And talk more and liberally to everybody about expedited partner therapy. It's supported in the guidelines for men who have sex with men and for partners now. So men who have sex with men were left out of the previous guidelines, and it is in the guidelines now. So do it liberally, and also talk about pre-exposure prophylaxis for HIV with all your clients. Next slide. Again, to emphasize, test at 3 sites, especially men who have sex with men, folks who are taking PrEP, and those with HIV. Also consider testing for hepatitis C, HIV, and syphilis at all these encounters. Next slide. We are an IM from the New York City STD Prevention Training Center. We have a lot of resources online that you can access. We also have a warm line, a clinical consultation line, where you can send us cases. Do not send us any patient-specific data, please, but we can get back to you and help you with any case that you need. Thank you so much.
Thank you so much, Dr. Neu, for sharing with us today. I know that we are at about time, but we are hoping to just stay on for a few extra minutes for those of you that are able to stay, and just answer a couple. I think maybe we really only have time for 1 or 2 questions right now. I know we've gotten several in the chat, as well as we got some from pre-registration as well. So I'm just gonna go with the first question that I see in the chat here. So Dr. Neu, somebody wrote in, how do you encourage these discussions when adolescents have parents that do not want this discussed?
Yeah, so that is complicated. You really have to talk to your medical director also about approaching it. But I would just say to parents, this is part of their health and well-being and positive sexual behavior for the future so that they can have healthy relationships. And if they're asking why, you talk to them about it. I also tell every parent that I have a private conversation with anybody 12 and older. Most parents will let you do that. If they don't, then it takes time. You have to build trust. And parents are part of the discussion. I wouldn't exclude them. That just is fraught with problems, but I would encourage them to participate in these discussions to help their youth stay healthy. Next slide. Oh, sorry. Next slide. Next question.
Lots of next slides. I know. This is a question that we received in the pre-registration. Someone asked, what do we do when we have young teens who need STD testing, but the state law says that they can only test with parent consent?
So I think I would go back and look at all the state laws. There are some laws that say that if they do the testing, they will tell the parents, or that they have to give the information to the parents. So I think I would review that again, if it absolutely, but you want to then approach the parents and also have it be, this is part of keeping their teen healthy. If we start at a younger age and this is normal part of what we do, then it's only going to be good for them in the future. But I think, definitely things are changing in the US. You have to be aware of what the laws are. And sometimes there's not much that you can do.
Yeah, thanks for sharing that. I'm just gonna ask one more question from the chat. And I know we're not getting to every single question, so please know that we will try and reach back out to you to answer all of the unanswered questions. But this last question is, what are your recommendations for routine screening for adolescents who do not share with the provider that they are sexually active?
I just say that I start screening my patients, at 14, because we know that or 16, we know that by 18, 65% of youth have had some kind of sexual activity. So oral sex counts. So I would just say it's part of what I do. Like, it's okay if you're not having sex. Let's just see what it's like. Like, pee in the cup. Maybe you're not used to doing that. It'll be a novel thing. um, and I just don't, if that's where you have to start, it's all about building that trust. This is going to keep you healthy, or especially somebody who's going off to college. Like it's good to know. You don't know when you're gonna have sex. Maybe it'll be next week. So know your test results before you start. I think we want to encourage everyone to know about their bodies, understand where they're starting from, protect themselves from STIs, and that's the most that we can do for them, and that's going to keep them healthy.
Great. Thank you so much for sharing that. And thank you everyone who put in questions into the chat for Dr. Neu. We will try and follow up as best we can afterwards to answer the rest of your questions. But I know that we're over time, so I do just want to close out quickly for today. So I hope you all take a moment after we close to go check out Q4T. A lot of the tools and resources and guidelines that Dr. Neu talked about are in the Q4T package. So definitely go explore the website, download the full package, maybe take the needs assessment or pick an improvement goal for your team. So we look forward to hearing about that. And then lastly, just as a reminder, we have 2 additional sessions coming up as part of the Closing the Adolescent Care Gap series. So we have session 2 on May 15th, and then session 3 on May 22nd, and we will be offering continuing medical and nursing education credits for those other 2 sessions as well. So we hope to see you there. And with that, thank you all so much for attending the first of our 3 sessions. I hope you all are walking away with some next steps on how you and your health center can use Q4T to improve services for the adolescent patients you serve, and especially regarding STI treatment and follow-up. So we will have a short evaluation as well. So we do ask that you take a few minutes to complete that. And thank you again so much. I hope you all have a good rest of your day.